So, good afternoon and welcome to this virtual meeting of the Health and Wellbeing Board. I am Councillor Jean Stretton and I will be chairing this meeting. Regulations have temporarily removed the legal requirement for local authorities to hold public meetings in person. However, the requirement for public meetings to be accessible to the public remains, and the link to this virtual meeting is available on the Council's website on the Live Meetings link page. If a connection to a member is lost during this meeting, I will stop the meeting to enable the connection to be restored. If the connection cannot be restored within a reasonable time, the meeting will proceed, but the member who was disconnected will not be able to vote on the matter under discussion, as they would not have heard all of the facts. Should any aspect of the external link fail, I may call a short adjournment of up to 5 minutes or so to determine whether the connection can be quickly re-established, either by video technology or telephone in the alternative. If the connection is not restored within that time, the meeting will be adjourned and any further business will not proceed until another time and date. Can I now ask the clerk to ask the members and our standing invitees to confirm their attendance?
Yeah. Helps if I'm not on mute, Chair. Sorry about that. Chief Superintendent Chris Alsop. No. Councillor Ball.
Present.
Mike Barker.
Present.
Councillor Bashforth.
Present.
Councillor Chowan.
Present.
Emma Davidson.
Present.
Val Hussain. Gerard Jones.
Present.
Stuart Lockwood.
Present.
Councillor Moores.
Present.
Joanne Sloan.
Present.
Claire Smith. Katrina Stevens.
Present.
Rebecca Sutcliffe. Councillor Sykes.
Present.
Tamor Tariq.
Present.
Mark Warren.
Present.
Liz Windsor Welsh.
Present.
Karen Worthington.
I've been asked to present, so I represent Karen Worthington, Jeanette Olsen.
Thank you. And Councillor Stretton.
Present.
Thank you, Chair.
Okay, we also have council officers from Constitutional Services in attendance. Whilst we meet formally as a committee of the council, the board is also a partnership in which we strive for consensus. Where we are required to make decisions, I will try to ensure we do this by general assent and only ask for a roll call vote when general assent is not shown. If the board is required to take a vote, each voting member will be individually asked to state whether they are for, against or abstaining. If we can now turn to the agenda, and for the benefit of those members of the public watching, the full agenda pack is available on the council's website. Do we have any apologies for absence?
We do, Chair. We have apologies from Dr. Keith Jeffrey, Dr. John Patterson, Majid Hussain, David Jago, Carolyn Wilkins and Donna Cesar.
Thank you. Do we have any items of urgent business?
There are none, Chair.
Very well. Do members wish to make any declaration of interest? I'll take that as a no. Members have before them the minutes of our last meeting.
Chair, sorry. Chair, I did put my hand up.
Sorry.
Yeah, thanks, Chair. Just my usual declaration that I'm an elected member at Bury Council. I'm also a member of the Health and Wellbeing Board on Bury Council as well.
Thank
Thanks,
you.
Chair.
Okay. So members have before them the minutes of our last meeting. Are these agreed as an accurate record? Does any member not agree? In which case, thank you, then the minutes are agreed. Have we received any public questions for this meeting?
We have not, Chair.
Very well. Item 6 is the terms of reference for the Health and Wellbeing Board, and this item will be introduced by Mark Hardman. Has Mark managed to reconnect?
Not currently, Chair. I can do my best by way of saying members have got the report. I'm sure you've all read it, and I will try to answer any questions that you may have. And Katrina's stuck her hand up, who may wish to speak.
Yeah, so I'm happy to just give a very, very broad overview, if that's helpful.
That's helpful, yes.
Yeah. So I think this item was originally due to come this time last year, although obviously with COVID that meeting was then stood down. The terms of reference have been reviewed in line with a wider review that's taken place of the council's constitution, really to just update and refine the content. The previous version of the terms of reference actually dated back to 2012, 2013, I think, when this board first came into existence. And obviously quite a few things have changed since then, not least in the wider landscape, things like devolution, integrated commissioning, better care fund, and also more recently this board has taken on additional responsibilities from the safeguarding board, for instance, for child death overview panels. So really any changes that have been made have been done to reflect those. I think these terms of reference are probably very much an interim holding position for the coming months, if approved. And we've got the white paper on the agenda later, which I would anticipate that we will need to do a further review in light of what comes from that, and integrated care arrangements coming into being. I have clocked this morning in going through the papers that there are a couple of references in there to a further review in March 2021, which clearly should read March 2022. So with those changes in mind to the paper, we'd be asking for people to accept the revised terms of reference.
Thanks, Katrina. Mike Barker.
Thank you, Chair. Wholly support and endorse what Katrina's just said. Perhaps I could try and help to firm up a timeline for us all in this group. Clearly, we're going into local elections in the not too distant future, so we need something, I think, to agree today. My understanding of the timeline around the NHS white paper, and I'll explain a little bit more about that in the another part of the agenda later on, is that we're likely to be looking at some kind of passing of legislation between now and the July recess for Parliament. I think if that was the case, then there's likely to be royal assent around about January time for the bill itself, assuming the government get that through. So it feels to me like a timeline of the autumn to review the terms of reference of the Health and Wellbeing Board would be a fitting timescale for us. I think the landscape will be a lot clearer. We'll know an awful lot more about we'll know an awful lot more about where we're at, and I think it would help us to move quite agilely into a new calendar year at that point, with some clarity about the future role of this board. I have no doubt in my mind that there'll definitely need to be some adjustments made to the scope, and I think we're probably going to expect guidance to come out around what happens in relation to integrated care in places at some point between now and the autumn time. Thank you, Chair.
Thank you. Any questions or comments? I'm not seeing any raised hands. In that case, thank you for that. We'll now move on to item 7, which is the refresh of the local outbreak management plan. And the item will be introduced by Katrina.
Thanks, Councillor Stretton. So you've got a copy in the papers of our revised or draft revised local outbreak plan. So we've, as a local authority, we have a statutory duty to have plans in place for outbreaks, and last June we were specifically asked to have a plan in place for COVID, as at that time we were coming out of the first lockdown. I think the focus at that time was particularly on how we manage outbreaks in settings, this idea that you'd sort of get mini outbreaks happening and you could stamp on them and contain them, and that would bring everything under control. And so the plan was very much written from that perspective. But that said, it has served us fairly well over the last 9 months or so, but given all the changes that have happened and the fact that we are now coming out of this more recent lockdown, it's a very appropriate time to review and update the plans. And at the start of the month, we were given a very generous 10 calendar days to turn around and submit a revised outbreak plan. So this is the paper that you've got is the output of that work. So within the plan, the content that is about the day-to-day management of cases and settings-based outbreaks is largely unchanged from what we had in the original version. But there are some specific areas where we were asked to give some additional focus this time, and also where things have changed substantially since the first plan was written. So they specifically relate to testing, to contact tracing, support for self-isolation, how we manage variants of concern, and of course vaccination, which was very much a kind of hope and dream for the future, I think, when we wrote the first plan, but is now very much with us as a programme that we are rolling out at pace. But also, I think it's really important that this new plan reflects the particular challenges that we've had with enduring transmission. So our high rates that we've seen haven't been just about kind of settings based and sort of clusters and small outbreaks that we've been able to get on top of. It's very much been more about dispersed endemic transmission in communities, and so much of that stems back to the structural inequalities that we know exist. So on testing, there is new content in the plan, which is very much about our expanded testing offer. So we've got lateral flow testing now available for people who don't have symptoms. And the aim here really is to make that offer as wide, as broad as possible, and to try and ensure we have high uptake right across the population. Initially focused on those who are not able to work from home, but I think over the coming months we will see that broaden much more as people start to circulate much more and come into contact with more people. Alongside that, we continue to offer PCR testing for people who've got symptoms, and critical there really is making sure that we can offer rapid access to our population in a way that meets the needs of the population as well. So ensuring that we've got flexibility in the local offer is really important for us, because we know that a one size sort of fits all fixed site, you must have a car to attend kind of offer really won't work for us. And part of that flexibility that we've tried to ensure we've got is to have a sort of locally commissioned offer that runs alongside the national offer, which does give us scope to do things like door-to-door testing, or to do pop-up testing sites, or to indeed to respond to outbreaks as well. With contact tracing, the changes are very much sort of things that have been happening over the last year, but I hope we will continue to see further changes in this part of the plan over the coming months. And there really has been a strong shift from the national contact tracing systems back into local over the last year, and I think that's been really welcomed, and that is continuing to happen. So over the coming months, I'm anticipating that we will get more control over the system. So rather than almost waiting for cases to be referred to us by National Test and Trace, we'll actually be able to look at live data as to what cases are on the system, and to be able to decide which ones and how many of those we want to take up and we want to pick up and contact trace within our own local teams. So I think that will be a really important enhancement to the system. Self-isolation, there are now new responsibilities for local authorities to provide support for self-isolation. So both in terms of administering some of the financial support packages that are available, but also looking at some of the wider support offer that's available, whether that's connecting people to organisations and people that can help with food shopping, dog walking, or any of the other things that you might actually need to leave the house for but not be able to do while you're self-isolating. I think engagement is really critical alongside that as well, to ensure and communication to ensure that people understand the offer, understand the support that's available, and also that that offer is clear at the point at which someone needs to access testing as well, because we know concerns about self-isolation are a real barrier to accessing testing. And alongside that as well, it's not just about that engagement with individuals, it is about engagement with businesses as well, so that they are supporting and enabling their staff to self-isolate. On variants of concern, I think if we do identify variants of concern locally, this is an area where we would very much be working in partnership with the regional teams, but also the national teams. And the approach that we'd need to take there would potentially involve things like surge testing, enhanced contact tracing, and additional comms and engagement work. So there's, within the plan, there is almost a list of the range of approaches that we might use, but what we've tried to make clear in the plan is that we would want to tailor that depending on what it was we were seeing in terms of the variant of concern, what and where in the population it had been identified. For vaccination, really it is about ensuring that we get high uptake and that our approach is reducing inequalities. So great work already happening on engagement on pop-up sites, and getting that really high uptake. So really a case of continuing that and learning as the programme continues to develop. I think with right the way across this plan, one of the opportunities we've had this time is to feed back on what additional support do we need from national and regional. So there is a separate document that went back alongside this plan to highlight some of those issues. And I think one of the key messages within that would have been give us the tools and resources that we can deploy flexibly, and that's critical with vaccines as well. Give us the vaccine and we know our population, we can roll it out, but we need the flexibility to do that in a way that suits Oldham, rather than being too constrained by a national framework. And then finally, on enduring transmission, I think all those elements of our plan and strategy that I've just talked about are critical to addressing enduring transmission. And it's really thinking about how we draw together everything we know about inequalities with our response to COVID, and making sure that that is a golden thread running through everything we do. Through an outbreak plan, we aren't going to tackle the structural inequalities that result in enduring transmission, but what we need to do is make sure that in our approach we are recognising the impact that those have and are doing our best to mitigate the impacts, and ensuring that that even if people might be more at risk of getting COVID, that the things like testing, things like support for self-isolation are there for those who need it most, and that people aren't disadvantaged in being able to access those things as well. So, as I said, we have had the opportunity to highlight back up to the national and regional teams about what we need. So that's really been focused on flexibility, on having the resources to deploy, but also ensuring that actually the approach that's taken does really recognise and address inequalities, and doesn't sort of seek to give us a one-size-fits-all Middle England type approach. The plan had to be submitted last Friday, a week ago last Friday, to the regional partnership team. So we're currently awaiting feedback on that. But the guidance that we'd had was that, recognising it was a very quick turnaround, that we can still make amendments to our plan following discussion at meetings like this. So with the discussion today, very happy to take feedback that can be incorporated into the plan. And then finally, just to say that there is an appendix which we've not included in the papers, just because it's got lots of detail in, like individuals' contact details, so not necessarily appropriate for public publication in its full detail, but very happy to share that with members of the board if anyone would like to see the appendices. So happy to take any questions.
Okay, so Mike Barker.
Thank you, Chair. I just want to shine a light on a couple of things. I think, first of all, just a huge thanks to Katrina and the team. I know she'll not take the credit for any of pulling that document together, but she should do. These documents often take an awful lot of people behind the scenes, do an awful lot of work to bring together, and it's never easy herding the cats. So congratulations. I think this is a really great plan. I'd certainly commend it and recommend it. Just to shine a light on the dynamism of this document, I think if we see this and never see her again, that would be a mistake. I think we need to keep bringing this document out, making sure it's congruent with what we're doing, and make sure that we don't just rigidly stick to it, but we change and adapt according to what's going on in our environment. So it's not meant to be a kind of stuck on the shelf plan. It's meant to be a guide and an aid memoir for where we need to go and how we need to get there, and make adjustments along the way. And you'll see the figures from things like the vaccination programme in there, which stood at that point at 76,000. We're now at 102,000 administered first and second doses, and that number's going to carry on going up every single week. And then finally, it's just a reflection more than anything. The 23rd of March represents one full year of being in national lockdown, pretty much. And I distinctly remember this time last year, and when I think back to where we were versus where we are, it's, oh my word, what a difference. And I think there's a real danger that we overlook some of that difference, that we don't write down in these plans. One of those things for me is, I don't think I'd really spent a great deal of time with Stuart. I seem to spend at least twice a week in a meeting with Stuart. I know more about leisure now than I did a year ago. And you could apply that logic to pretty much every part of our system. And the plan is a reflection of just how much we have been able to bring all parts of our system together to solve problems. And we can call it a pandemic, and we can call it a variety of different things. But underneath it, there is a principle actually of, when the whole of Oldham comes together to do great things for great people, we can achieve so much. And this plan is a reflection very much of all of that work together. And my view is, long may it continue. We have to learn from that and build on it as we go forward, as we bring back services in this next phase. Thank you, Chair.
Thank you, Mike. Rebecca.
Hi, everyone. I just wanted to just kind of make a couple of reflections really on the kind of inequalities theme that Katrina pulled out, because I think that everything that Mike has just said is absolutely true. One of the other things that we've really learned throughout the pandemic, of course, is increasingly that understanding of the impact of inequalities upon health outcomes, including the way that our population have been able to respond to and are impacted upon by COVID. So during the course of the last year, we have established Inequalities Advisory Group. We've got 2 pieces of work that are in draft, an equality strategy and a multi-agency poverty action plan. And in both of those things, as well as through this local outbreak plan, we are articulating a kind of greater and enhanced commitment to recognising and responding to inequalities. So I guess in the endorsing of this local outbreak plan, there just is that question as we roll forward and as we think about our role as a health and wellbeing board, that we, as we dynamically update it, that we have the confidence and challenge each other to pose those questions about whether we are responding to the inequalities that we are exposing. So Katrina and I had a conversation prompted by Katrina just this morning about, about what our testing and vaccination strategy will be going forward, and the degree to which we are prepared to be explicit about our commitment to addressing inequalities. So it's more of a kind of observation rooted in, yes, this is great for where we are now, but as we look forward and we think about our role as a board, I think there is something really about having that determination and that a sense of responsibility about and commitment to continuing to identify and address those inequalities.
Thank you. Councillor Cathball.
Thanks, Chair. I'm really pleased with how we've dealt with the problems of people who haven't got digital access and have no mobile phones when it comes to the testing and the vaccinations, because it has been a real problem. You can't get your results, you can't book on, and I think we've come up with various means of circumventing this so that it works for everybody, and it's a big thank you for that.
Thanks for that. Councillor Marie Bashforth.
I just wanted to say thank you, Katrina. That's an excellent review. One of the things that jumps out to me a lot is through my casework is from residents, obviously, that struggle with the idea of going into isolation because of maybe where they work and the problems that they won't get paid while they're off work, etc. So I can see in the report that there's going to be some communication material coming out to help us with that. So if it could be made quite a clear pathway for families to see how they can apply for financial support and all the other things that can come with that, I think that would be an excellent way to go forward with this. And also, as Mike says, we need to just be revisiting and relooking and moving forward and taking it as much as we can as we, as the months go on.
Thank you, Marie. I've got Tamar indicating, and then I think Katrina wants to come back in.
Thanks, Chair. Thanks, Katrina, for this piece of work. I think it's a really good and important piece of work. I just add, so at the end of last week, colleagues will be aware, I know, Katrina, you were copied in, and Mark and others, in terms of the work that we've been doing at Health Watch around the COVID-19 survey, which has been quite an extensive piece of work. The survey started before I arrived, and we've just concluded the final report, which is out to partners and stakeholders for the 14-day window where we're inviting people to have an input and feedback on any of the recommendations that we put forward that relate to your specific service area or department. And I think it's important. Obviously, every local authority has a local outbreak plan, but building on what Rebecca's saying, I think the last 12 months have kind of, as well as given local people a bit of a shake-up, I guess, in terms of living through a global pandemic. I think that shake-up has obviously hit the local system as well. Understanding what are some of the pressing long-term health and social care issues that we've got in Oldham, how do we tackle them as a system? And COVID-19 has given us that opportunity to look at things as an afresh. And there have been gaps that have been picked up along the way, and some have been addressed and some that continue to be addressed. All I would say is around the local outbreak plan, I think it's really important that patient engagement and patient experience is very much at the heart of everything that we're doing around, whether it's looking at the local outbreak plan or looking at wider commitment to the system around health inequalities. I do think we need to look at bringing the community with us and bringing them closer to decision making. And I know there's lots of work going on around public sector reform, the INTs, working with primary care as well, social prescribing. There's so much that is going on, but it's something that we've just got to be mindful of. And I hope that the report that we've submitted, and when people have had a chance to have a look at that, that'll give a flavour of people's experiences of the last 12 months and give an indication of people's insights, particularly being reflective of the whole Oldham demographic. Once we've got feedback from stakeholders and partners, we will be publishing that report out in the public domain. So I hope those people that I've sent the report to last week, if they're able to kind of look at that and comment, that'd be much appreciated. Thanks, Chair.
Thank you. I've got Zahid Charan would like to come in, and then I'll bring Katrina in after that. That's okay. Thanks.
Thanks, Chair. I will be very brief. I think first of all to say thank you to all our partners. Probably this is the best place to say thank you for everything they have done over the last 1 year. I think I'm sure without partners' contribution and pulling things together and going over and above, we would have struggled to get where we are today. So big thank you on behalf of Oldham Council. I think the second important bit is we've done well, but I think it's also opportunity to reflect and learn where we did not do well. Historically, why we are where we are. I don't want to expand and use this brief time for the discussion, but as a health and well-being board, we need to reflect what we will do differently than if 5 years time, 10 years time, or my grandkids' time we have another epidemic similar. We don't have so many people die in our streets. But also probably use this opportunity to say sorry to all those who lost their lives, but also who survived but still suffering and will have some ongoing suffering for a very long time. Thank you, Chair.
Thank you. Katrina.
Yeah, just to say thank you to everyone for their comments, and as Mike said, it was very much a team effort, and so particularly policy team who did a fantastic job in putting it together, but also Mike, Claire, there are plenty of others on this call and more widely who've written significant sections in the plan, so thank you for that. And then also just on Councillor Bashforth's point about self-isolation, I think, yeah, having that clarity of what support is available and how you access so that people are aware of what's there before they even need it, I think is really critical, because we know that will impact on whether people even go to get a test in the first place. I think as well, we know that the support is part of it, but actually job security is something people are really concerned about if they have to self-isolate. So having the support available won't solve the whole problem, but so there's work to do with employers, I think, as well. And I think the other element of it as well is that there are huge sections of the population who won't need to call on financial support or other support, but will call on the support of friends and family. But we need everyone really to think about what they would do if they did have to self-isolate and where that support would come from. And I think back in the first lockdown, everyone was much more in that mindset of checking in on neighbours. Did anyone need anything? Maybe expecting to have to go and pick up shopping for someone who was self-isolating. And I think we've lost some of that over time. So I think there's an opportunity to kind of reinvigorate some of that sort of friends and family approach as well in the work we take forward on self-isolation.
Thank you for that, Katrina. Zahid, your hand's still up. Is that because you want to come back in?
Sorry, that's a legacy hand.
Okay, thank you. Okay. Okay, then to echo the thanks of various members of the board to Katrina and the people she called on to enable this to be pulled together at such short notice. Very well. Okay, so. We're asked to endorse the refreshed local outbreak management plan. Is the board happy to accept the recommendations?
Agreed.
Does anybody not agree? In which case, the board is happy to accept the recommendations. Thank you very much. Okay. Item 8 is a briefing on the NHS White Paper, Integration and Innovation, working together to improve health and social care for all. And this item will be introduced by Mike Barker.
Okay, thank you, Chair. I'll try and be reasonably brief and to save members the hassle of trying to turn the pages, maybe just give you a quick overview of what the legislation is. So just before Christmas, the NHS England unveiled some proposals really for moving forward with the next stage of the NHS long-term plan. They were broadly entitled Integrating Care, and they outlined a series of potential changes that NHS England thought might be useful to move the NHS into this next stage of its journey in honouring the commitments in that long-term plan. There was a deadline of the 7th of January, as I recall, for systems being Greater Manchester to respond to that initial document from NHS England, and I believe Greater Manchester did indeed make a response. And then in February of this year, the Department of Health and Social Care published proposals for new legislation, the title of which the Chair's just outlined. That was in the form of a white paper largely focused on NHS England, but also limited some proposals for social care and public health within the body of that document. The document itself broadly covers 4 different areas. So the first one is about working together and supporting integration. There's something in it about reducing bureaucracy, something about enhancing public confidence and accountability, and then the additional areas around social care and public health, with all changes planned to be implemented from 2022. Again, it's a white paper, and a white paper requires to be turned into legislation via a bill at some point before anything can be implemented. So we're now in a phase where the period of consultation is closed, and at some point between the House returning from recess in April time and rising again in July, I imagine there'll be a bill put forward by the NHS, or by the government, I should say, for changes to the NHS. For me, the white paper is a story of several parts, really. The first part's about encouraging collaboration within the NHS and between health and social care by removing some of the 2012 Act rules on competition and procurement. And those people remember the Act brought forward by Andrew Lansley at the time that saw the abolition of PCTs, the dissolution of things like public health, and putting them into local authorities, and a variety of other different proposals, one of which though was, however, making the NHS dependent on Competition and Markets Authority legislatively, and the new proposals talk about removing that. The second part of the white paper is then really about changes to national roles and powers over the NHS, and that does include strengthening ministerial control of the day-to-day running of the health and care system. And then the final part, for me, is probably much more about things that are lacking or missing as I read it, particularly I'm sure Mark will join me in kind of wondering and scratching his head about where is the green paper for social care that we still have not had. And it's all right putting a few clauses in these proposals about changes to social care, but don't fundamentally address the underlying issues around the lack of a future strategy for social care. So in terms of the first bit about collaboration and integrated care, the big changes are a shift for every single part of the country to be covered by an integrated care system, which will control most of the NHS resources. And for us, that system will be organised at Greater Manchester level. And in order to achieve that, that will mean the abolition of local-based clinical commissioning groups. So in other words, at some point in time, likely April 2022, Oldham CCG will cease to exist, and its powers and functions and responsibilities and people are likely transfer to something that's called the Greater Manchester Integrated Care System, yet to be determined what the format of that looks like. The legislation, though, envisages 2 forms of the integrated care system operating at that level. One will be an NHS board and one will be a partnership board, and the 2 things will work alongside each other. And there's a whole load of work going on across Greater Manchester at the moment to try and describe and identify how those 2 things will intertwine with each other and what that will mean for places and localities, places being Oldham. And quite strongly in the document, it talks very clearly about the integrated care systems needing to work with local places, and making sure that there are local partnerships in place with delegated budgets and power and authority to be able to work with the local population and focus much more on population health as a core principle. And it also envisages the removal of the competitive nature of health services at the moment and replacing it with a collaborative framework. So in other words, the way that we currently tender services at this point in time is likely, and in fact will change under these proposals, but it doesn't say what that will be just yet, other than there'll be some kind of selection regime for determining how contracts are awarded, and it will not be in line with the current way of doing things. So the competitive tender obligations will be removed. Similarly, the removal of the Competition and Markets Authority, which generally applies to organisational transactions, will also be removed. And Oldham is not blind to organisational transactions, given that we are still pending the completion of a transaction of a merger between Salford Royal Hospital and Pennine Acute Hospitals to form a new Northern Care Alliance, and that is now delayed by 6 months, not as a consequence of this, but as a consequence of the pandemic. But it will change the the overarching regulation and governance processes to make those things happen. Turning to national roles and powers, the first big change really proposed is a formal merger between NHS England and NHS Improvement, which will provide a unified leadership for the NHS. And the second most important thing in the proposals then are broad intervention powers for the Secretary of State over the functioning of the NHS, and they will include but not be limited to formally directing NHS England in relation to what it describes as relevant functions. So in other words, whatever the minister so decides based on a set of criteria. It will allow the ministers to intervene at any time in service reconfigurations, and of course that is a power normally currently reserved for overview and scrutiny committees in local authorities or across systems. So we've seen some of that already with the change of Chorley Accident and Emergency Department, the local system wanting to close that down and turn it into something different, and the Secretary of State now deciding that that's not going to happen, which is against the clinical opinion of that area. The Secretary of State will also be able to abolish and transfer either arm's length bodies or transfer the functions between and from. So some quite wide-ranging important powers there that change. From the final part of what's in the document, talks about workforce, and it's very laudable for the Secretary of State to publish every 5 years something that sets out the roles and responsibilities for workforce planning, but the document doesn't actually tell you what that really means and what that's going to do. And given that we've all got pressures around workforce, it doesn't really talk about strategies in a long-term way. So more, I think, will need to come out in the guidance for implementation around what that particularly means. And similarly with public health, I have to say from a purely technical point of view, somewhat randomly and out of the blue, tackling obesity, don't necessarily disagree with that, and moving water fluoridation responsibilities, I find a little bit odd. There's a mention of fluoridation in there. I'm sure Katrina won't want to go back over that 12 years ago, but there you go. And quite a kind of overarching, wide-ranging, bland statement about NHS England public health functions and the Secretary of State powers to direct them, but it doesn't really say what that means. It doesn't really say how, and it doesn't really talk about the connectivity with local authorities or places. So, perhaps more significantly, there is no cross-cutting government strategy for reducing health inequalities with adequate funding mentioned anywhere in that white paper. And then when it gets to social care, yes, stronger central oversight of some things, and a new legal framework for discharge to assess. I'm sure Mark will join me in welcoming the news that I think is likely to come out in a short amount of time about planning for next year, that talks about how we continue discharge to assess funding in the new financial year, but we don't really provide any long-term platform about what social care looks like and the interfaces and interactions that it has with the NHS. So, but broadly, that's an overview of what the white paper says with a particular lens upon it. And I tried to place into today's papers for members some discussion points really that might be used as a hook. On the positive side, for my observations, there was a real moment when it could have saw the abolition of health and wellbeing boards in local places. It's not chosen to do that, but I think there will be a commitment and a need to level up, for want of a better phrase, all health and wellbeing boards to the performance of the best. And I think that in itself gets back to Katrina's point at the start of the agenda about the terms of reference and the work programme in front of us on this board. There is something quite significant about the shift away from the adversarial nature of transactional system-based NHS contracting into a much more collaborative space, and what that will mean culturally in our system and how that will work. And I think that we should be welcoming those things. And then the other thing I would pull out quite specifically then is the need to make sure that not only do we continue to push for better and greater clarity around social care of the future, but closer to home, that we work collaboratively as a system called Greater Manchester and make sure that we get the balance right between what happens at a Greater Manchester system level and what happens in places, not just in terms of decision making, but certainly in terms of the allocation of resources to tackle problems. It's my firm belief that Oldham knows what's best for Oldham people. It's got the data, the intelligence and the insight to be able to do that. We're showing it all the way through the pandemic for the past 12 months. We need to work pretty hard, I think, over this next 12 months to make sure that GM continues to work effectively and efficiently, and we have the right balance of decision making and authority in each of the spatial levels associated with health and care delivery. I'll stop at that point, Chair. I'm more than happy to take questions, but I suspect it's probably more worthy of a debate rather than just questions of me. Thank you.
Zahid.
Just to first of all say thank you to Mike and other colleagues who led on this work. It's a lot of work being done behind the scenes on GM level, trying to fight for a right model for Oldham to ensure. So key principle in setting these plans were ensuring that we have a local power to make local decisions, democratic accountability, and the model we can choose, the one fits for Oldham, not the one is being dictated nationally or regionally. And I have to say it's not been an easy journey, and I suppose it's not over yet, technically speaking. But it's important that our one team, one Oldham team approach can be maintained and sustained only if we have a local decision-making powers in terms of how we want to deliver model. But also ensuring that our voluntary sector, which is always taken for granted, are part of actually commissioned services arrangements, where we're not just relying on the goodwill, but actually we're supporting that sector to thrive and do more and more and more, but they get some sort of like reward as well. But it's trying to design our own older model. So I mainly wanted to use this opportunity to say thank you to Mike and other colleagues who have significantly contributed to this work program. That's clearly our vision for Oldham, which we're trying to outline. And I hope that we will have support of our colleagues in this board, but also positive and negative feedback so we can get to a final version which is really suitable for our residents. Thank you.
Mark.
Thanks, Chair. Just to add to Mike's points, really, Mike's report kind of highlights and summarises the document. So just to add to a couple of the points, really, just in terms of the funding, as we know, the Chancellor was silent in terms of the challenge which continues to be adult social care funding. And I know elected members on the call receive regular contacts from Oldham citizens confused about the charging situation. I know Councillor Sykes, you've raised quite a significant one with regards to self-funders over the last week or so. And I think one of the things the white paper does, just to be clear, that whilst the green paper, we don't have a date, then Part 2 of the Care Act, which was not enacted, did actually set out what the charging requirements would be in the cost of care. However, the white paper does go on to talk about understanding the fees paid by self-funders to contribute towards an understanding of what the gap is for the lifetime cost of care for people in terms of how we move forward. And it's interesting within the white paper that some of the detail talks about data on hours of the number of hours provided and commissioned care, cost per person, and data and financial flows which local authorities will be required to provide going forward. Mike's talked about the new assurance framework, but just to flush out as well that there will be a CQC duty to assess local authority delivery of adult social care duties alongside powers of the Secretary of State to actually intervene where a local authority is deemed to be failing, and that is a considerable change in terms of where we are actually at this particular point in time, and quite a bit of discussion across adult social care around what that actually means, including discussions with CQC as to whether or not that should be more along the lines of sector-led improvement as opposed to a mirroring of the Ofsted approach within children's services. And then finally, just the point that Mike made with regards to discharge to assess, so that the Care Act requirement at this point in time is to assess somebody actually on the ward. Obviously that would be lifted, and therefore we're going to need to find ways to ensure that we still find person-centred ways to enable people to move off the ward to wherever their next stage in their discharge journey actually is, and those financial penalties for delayed discharges, whatever they mean, would actually be removed as a consequence.
Thank you, Mark. Liz, Windsor Welsh.
Hi, everyone. Thanks, Mike. I also agree that was really helpfully laid out. I'm interested in two things really. One is what's the process of decision making for what we can control within the part of the system that's going to stay in Oldham. So it's kind of what's the process by which we design that together. And then secondly, I think you raise an important part around health inequalities, and that is not explicitly written in, but I wonder whether there is an opportunity to design that in, and where we have control, can we explicitly design that into the modelling that we create, so that we can commission to tackle inequalities and really make sure there is focus on prevention. Because the greatest risk that I can see is that this is a distraction to the really important work we need to do, and in some ways it fragments that opportunity. Now, it could also provide an opportunity, but it's got the potential to fragment as well as build the right kind of collaboration.
Thank you, Liz. Katrina?
Thank you. And yeah, one of the points I was going to make relates to what Liz has just said directly, I think, in that I think it's interesting, isn't it? In the middle of a public health crisis, you have an NHS white paper, and actually it's the first time I've seen an NHS white paper with public health written so prominently through it. I think there's 70 or 80 mentions of it, and that's not happened previously. However, I think there is a task for us in how we really make that a reality, in terms of actually using that as our hook to really think about how we build in addressing health inequalities into everything we do. And you know, interested in Mike's view on this as well, but I do think we've got scope in there, particularly with the focus on place and on the population, and not just on patients. That kind of shift to thinking about public health right the way through this document gives. To just pick out a couple of the specific public health bits in there as well. The paper references the changes that are happening nationally around the organisations that will be the successor organisations to Public Health England. Still very light on information on that at the moment. However, I would anticipate we will know a lot more by this time tomorrow, as the Secretary of State is speaking to the LGA and ADPH conference tomorrow morning, and I believe that is the main focus of what's going to be presented. And then, yeah, obesity and fluoridation do feel a little bit out on a limb as very specific points in there. I suspect some of that is about things that need some primary legislation to do things, and certainly on fluoridation, I think what's proposed in here does make absolute sense. Giving the powers to local authorities was always a challenge, because water supply systems don't follow local authority boundaries. So it's pretty much impossible for an individual local authority to make a decision about putting fluoride in the water supply when it affects neighbouring areas as well. So actually, that being a Secretary of State responsibility does have an element of logic to it. I think for us as a board, though, there is consideration for us for the future about actually what, if that power does sit there, what does that mean for us in terms of what we might want to lobby for as a board, or request of the Secretary of State in that regard. And you know, that's a discussion for another time. But.
Thank you, Katrina. Mike, do you want to come back in?
Oh yeah, so I'll come back on Liz's point really. Probably a really salient point, isn't it? I think I've lost count of trying to describe the amount of boards and meetings that take place across the whole of Greater Manchester, from the Partnership Executive Board, commonly referred to as PEB, to the Joint Commissioning Board, which is commonly referred to as the JCB, to the Health and Care Board. All of those main decision-making boards have quite a lot of infrastructure built around them, and on the one hand, some of this will end up being determined for us because of the way the changes will be made. And Katrina's point, and I don't think we should overlook or underestimate this. In the middle of a public health crisis, why on earth do we want to reorganise the NHS? That's a very kind of pessimistic way of looking at things. A more optimistic way of looking at it is, why wouldn't you? Because there are some things that we could fundamentally do better, differently. And what the white paper really, really does talk about is strengthening the role and input and influence that places have over themselves from a health and care point of view. But to do that, there's got to be a trade-off by aggregating some decision-making powers to a higher level. And in our case, that's Greater Manchester. And therefore, we have to recognise that Greater Manchester is massively more advanced than other parts of the country. It's got a really big infrastructure around decision making, and Zaid, or Councillor Chown, I should say, has already mentioned this. There's a great number of us working in different fora to try and influence what these proposals look like from a GM point of view, as it describes the next stage of its journey. Because I believe the white paper already fundamentally describes what happens in GM now. The important thing is, how does GM move forward, and in what basis? And undoubtedly, we're going to need to get into a conversation about what activities take place at what level in Greater Manchester as the CCG disappears. What functions should reside and be retained at a locality level? My personal view is the majority of them, if I'm being blunt. I'm less concerned about elective activity. I think you can commission a lot of that once across Greater Manchester footprint, but when it gets to medical specialties and outpatients and how people actually access services on a day-to-day basis for non-planned work, I think that really should stay within the locality, and that's the kind of conversations going on across the whole of GM at the moment. And it will take all those statutory organisations to come to a conclusion and a consensus on whether they all agree with that type of approach. And I'm pretty confident, I don't know, Councillor Chowan feels, he and I both sit in JCB at the moment, that we will find a way of reaching a consensus. We're not far off that right now. And at that point, it'll be game on to start really designing how that needs to work in different places. But, the initial thinking for me is very much clearly around Greater Manchester receives the allocation. There's a formula that determines what Oldham's cut of that allocation is. It gets delegated down to Oldham into a system budget, and there is a system board, which we're currently working on, being the Commissioning Partnership Board in Oldham, and in its next stage of evolution, that receive that money and allocate the resources in a holistic way, where we've got the commissioners and providers at the same time, sat in the same room, and we've got the voluntary sector with the statutory sector also sat around that table at the same time, which is a bit of a difference, but that will be the board that sets the strategy, the ambition and the outcomes based on need and population health analysis, that oversees then a more integrated, collaborative way of delivering across our system, bringing all the partners together that need to be. That's the theory, that's the logic. I don't think that logic's different in any of the 10 places. And in fairness, it's not far off the logic that we've already got with, and Oldham does not have formally an LCO, but other places do. We have an alliance. It's about building from that point, Liz, and I think we need to see how this falls out. My sense is that on the other side of Easter, we'll have a HR framework which will be pretty descriptive about how we need to deal with the people side of things, and we'll also have a set of guidance documents about what's to be expected by places, and that then will, I think, start to shape an awful lot more. I think the most important thing for Greater Manchester at this point, and Oldham in particular, is we don't give ground and move backwards. We need to move forwards, and there's a real danger when you look at the white paper. It doesn't go necessarily as far as GM's capable of going, and therefore we end up falling backwards a little bit. We shouldn't do that, and that's probably the big conversation that's taking place in Greater Manchester at the minute. Thank you.
Thank you, Mike. Does anybody else have any further questions or comments? Okay, well, the report is presented for information. Is the board happy to note the report? Does anybody not agree? In that case, the report is noted. There are no further items on the agenda other than to note the dates of the board meetings in the next municipal year. And the next meeting will be on Tuesday, the 26th of June at 2 p.m. And all that remains for me is to thank you all for your attendance. Obviously, there's some very busy people on this call. Thank you for taking the time to contribute to this board meeting.
Thank you, Chair.
Bye.
Thank you, Chair.
Thank you, Chair. Bye.